We're going to start with the lower extremity today, and we'll get up hopefully to knee. We'll see how it goes. So we'll start with anatomy, and there are some similarities between upper extremity and lower extremity in really imaging and understanding positions and the things you have to accomplish to get like open joint spaces and things like that. So generally speaking, people do a little bit better on the lower extremity than what they did on upper extremity. So we'll see how that goes. So in the foot, advance this. So in the foot, we have imaging challenges that aren't as obvious as what they once were. With film radiography, because of the thickness difference, we would, there we go. Yeah. We would have to select a technique that would enable us to either shoot the distal end of the foot or the proximal end of the foot. With our computer processing, that's really not an issue anymore. So what you may see in maybe all the way through the registry test questions reference to different types of filters, and the only real filter that we've talked about so far has been inherent filtration, but there is such thing as additive filtration. And what additive filtration does is it either increases the energy level of the minimum x-rays, thereby further reducing the output of the x-ray tube, or we've got what we refer to as compensating filters. And compensating filters compensate for anatomy, tissue thickness differences, and things like that. So if you happen to see one of those, this is the first place that we're going to talk about where you might utilize compensating filter. You probably won't, because again, the computer algorithm allows you to visualize both the distal and proximal end of the foot. But because the foot is a wedge shape, it's pretty steep wedge shape in some people, toes being relatively thin and the proximal portion of the foot being pretty fat, what we would have to do is utilize a filter, and it's just a chunk of aluminum, and the fat end of the aluminum would go over the toes and absorb more x-rays before it reached the toes, and thereby lighten the density over the toes. Does that kind of make sense? The proximal end of the foot was thinner, so it absorbed fewer, more x-rays got to the image receptor, and it would even out the tissue density differences between the two ends of the foot. So that presented imaging challenges that just don't really exist anymore. We used to use those on lateral C-spines, APT spines, things like that. And we just don't need them anymore. But you may see reference to that. It's still good. We needed that. We needed a challenge this morning. There we go. But it is not as much of an imaging challenge as what it once was. So you may see a reference to it on the registry, and that's what it's talking about, is compensating filter compensates for tissue density differences. It's just a chunk of aluminum in a wedge shape in a lot of cases. So in the toe, we got considerable differences in thickness, and therefore radiographic, I'll go ahead and say densities, because the proximal end, the bones are a little bit thicker than they are at the distal end, but certainly thickness. You got 26 bones. You've got, just like in the hand, you had carpals and metacarpals. In the foot, you got tarsals and metatarsals. Metatarsals form the what we refer to as the instep, and they give you the arches. So you've got two arches. One is pretty obvious. You look at somebody's foot from the side and you can see the arch, and that's what we refer to as a longitudinal arch. But you've also got another arch that's less pronounced that goes across the foot, and that's called a transverse arch. So those are formed by the metatarsals and also the tarsal with the heel bone, kind of protruding downward. And then of course you've got the phalanges as well, just like in the fingers. In the phalanges you got 2 in the great toe and the big toe, and then 3 in the rest of them. Our counting of the phalanges and the metatarsals are going to be exactly opposite, and yet still in a weird way the same as what they were in the fingers. And fingers were counted outward in from the fat finger, right? Fat finger was the first one. So it goes from outward inward, 1, 2, 3, 4, 5. And in the toes, it still goes from the fat to the little one, but it's going to be from inward to outward. So the first toe is going to be your great toe, and then 2, 3, 4, 5 inward or outward from that. So, you know, of course, they're named also by their location. Their interphalangeal joints, the phalanx, individual phalanx known by their location. The interphalangeal joints, remember in the first one you only have one. The rest of them you've got two. So you got distal phalanx, middle phalanx, proximal phalanx, except for in the first toe, you've just got distal and proximal. And then your interphalangeal joints by virtue of where they're located, so proximal or distal, right? So you've also got 5 metatarsals. Proximal end is the base, distal end is the head. So your tarsal bones, the most significant of your tarsal, they've made them a little bit easier to remember in a way, and that's a good thing. But the bad thing is they don't really stress this. I don't know that I've ever seen test questions in the registry review books that just say a whole lot about the metatarsals or the labeling of the metatarsals. So it made it easier in that you've got 3 bones that are named exactly the same thing. That's the cuneiforms, and their position is just where they are, lateral, medial, or internal. But we just don't label them all that much. So the most significant of the two would be the calcaneus and the talus. So the talus is the bone directly above the calcaneus, and it forms a portion of the ankle joint. So you've got the tib fib that come down, and they kind of surround the talus to form the ankle joint, or what we refer to as the mortise joint, and we'll talk about that here in a bit. Calcaneus is your heel bone, and then you got the navicular, your cuboid, and your 3 cuneiforms. So you got intermediate, medial, and you've got the lateral cuneiform. The cuboid we will reference in our obliques so that we can determine whether or not our degree of obliquity is good. And that is your evaluation criteria. One of your main evaluation criteria is for your oblique. That is that you should be able to see the joint space all the way around the cuboid. And aside from that, there's just not a whole lot on it. So calcaneus looks like that. In my experience, I don't know statistically, but in my experience, this is the most commonly fractured of the tarsal bones. So somebody falls from a ladder or falls from a height, and lands on their feet, they'll break their calcaneus. In a lot of cases, it's going to be a comminuted fracture, and they may have to go in and they may have to plate and screw it. There used to be a orthopedic surgeon here in town who would just put pins in various places to try to stabilize all the individual little pieces to it. And that was kind of wild. Anybody ever seen Beetlejuice? We're coming up on Halloween. Yeah, when the guy's holding him and all of a sudden all these spikes stick out of him. That's kind of what the guy's heel looked like, was Beetlejuice with spikes sticking out of him. So these things would just be poking out at random different angles. He seemed to get a good outcome from it, so whatever works, but he's the only one that would do that. So talus is directly over the top of it. Again, it's the bone that articulates with the tib fib to create the ankle. Cuboid's over there, and then you've got the navicular, and then your cuneiforms here. Okay, so you got a mnemonic for that as well. Never once have I ever heard anybody reference this mnemonic. Again, the tarsal bones just aren't stressed as much as what the tarsal bones are. So the ankle joint, again, is formed by the articulation between the talus and the distal portion of the tib fib. So you've got 2 knots that you can feel on the lateral and medial side of your ankle. That's what we refer to as the malleolus. You got a medial malleolus and you got a lateral malleolus. Sometimes you'll hear it referred to as the malleolus. If you're spelling it out, I can just tell you, malleolus is a whole lot easier to keep in mind when you're spelling it out. It just, it's a mnemonic thing. It's easier to spell out. But when you're saying it, it's malleolus. Anybody who says otherwise, they're just wrong, because I'm right? So it really doesn't matter either way. It's kind of like oblique. Anybody heard radiologists say oblique, or anybody else? No? Okay, well, I stand firmer on oblique than I do malleolus, because name me one other word that ends in IQUE that ends also pronunciation-wise in ike. Antique? You know, you got a piece of furniture that's 100 years old, is it an antique? No, it's an antique, right? So anyway, those are your malleoli, and you've actually got one in anterior and posterior side as well. So your joints, that joint, your ankle fractures, most of the time, just like in the wrist, most of your ankle fractures are not going to involve, you know, the ankle bone of the talus. Some will, but most of the time it's going to involve the distal portion of the tib fib. So what may happen is you may snap off the medial malleolus, or you may snap off the lateral malleolus, or you might break both of them. It may be a little bit of a more proximal but still distal fibular fracture, not quite to the lateral malleolus. And then you've got the, that's lateral malleolus, medial malleolus broken off as well. That's what you refer to as bimalleolar fracture. So if you have seen, or you will eventually see a repaired ankle where they've got a screw going up into the medial malleolus, and then you've got plates and screws on the lateral side, that's what that is. So your ankle fractures, just real quickly, and we're going to get into this here in a little bit and talk about highly unstable ankle fractures, but most of your ankle fractures are pretty stable. And I don't mean that the patient can get up and walk around on them. I mean the patient can pick their leg up and put it on the image receptor, okay? And that is because you've got, it's not unique to the leg, but you have these all over your body. It's what we refer to as a syndesmosis. Now, syndesmosis is a soft tissue joining of things together. So think of it in the leg kind of like a compression sock. And it goes from the ankle all the way up to the knee, okay? So the tibia and the fibula don't really move much in relationship to each other. One provides stability to the other. The tibia is your main bone. The fibula provides some stability, especially in the joints proximal and distal. So that syndesmosis is kind of what keeps those two things tightly bound together so that they don't, you know, there's not a whole lot of movement. Without that, then the bones could, you know, separate a little bit here and there, and your ankle would dislocate very easily. So your very unstable ankle fractures is where that syndesmosis is disrupted. So if you see an ankle fracture, a repaired ankle fracture where there's a screw that goes all the way across from fibula to tibia, then what they're trying to do is they're trying to reestablish that syndesmosis. There's some sort of damage to that syndesmosis. So it's a little bit more unstable. We're going to talk about highly unstable here in a bit with a specific type of fracture and what you need to do with those. But if you see that screw going all the way from one bone to the other, it's because that syndesmosis is, you know, it's disrupted. It's not as stable as what it could be. So, ankle. Just allow slight abduction, adduction, a little bit of rotation, but for the most part, it's going to be a hinge joint. So, I mentioned this before, the joint space all the way around is what we refer to as the mortise joint. So this is the lateral malleolus off of the fibula, medial malleolus here. The anterior and posterior portion actually drop down a little bit, and some textbooks may refer to it as a malleolus as well. And you can kind of see it on the x-ray. You might not be able to see it very well up here, but in your textbook, you should be able to see that little shadow right back there. And that's what we would refer to that as posterior malleolus. Now, you can also see on this image that little dark area right there, and that's kind of the cradle for the distal portion of the fibula. So you've got that articulation between the fibula and the tibia distally here, but you've got some superimposition in AP, and we're going to talk about how we can both see the mortise joint and also see that without any kind of superimposition here in a bit. So you got a couple of sesamoid bones. Let's go back up to here. You see those little dotted lines right there? Okay, those are sesamoid bones, and they're right up under your big toe. And sometimes those will break, and I think I've mentioned this before when we were going through sesamoid bones in the upper extremity and just general different types of bones. Those will break sometimes in people who do high impact athletics. Football players, pretty common. Dancers, though, you know, you got ballet dancers and things like that that wear those things that have those shoes that have really no padding on them at all. They land on their toes and they can break those relatively easily. You know, a severe case of that would be what we refer to as turf toe. I know this is a long time ago, and y'all may have never seen Deion Sanders play, but he was out for an entire season for turf toe. It just sounds like something, you know, you should be able to take a couple of aspirin for. I can tell you from experience, again, I used to play paintball. I was in the woods, and a guy would come through and he'd just mow everything down with a, you know, tractor, brush hog. And I was at a full run and I stepped on a sapling that only got mowed down to about that high, right on my big toe on my right foot. And I don't think I ruptured anything or broke anything, but I hobbled around on that foot for months. So true turf toe or broken one of those, I can't imagine, you know, how long and painful the recovery for that would be. So those are sesamoid bones, right? So now we're going to talk about toes, foot, calcaneus, and ankle. I hope to get through knee today. Tib fib is, you know, it's just too confused. Tib fib. It does bear some explanation on things that you should do if you know that you've got a patient with a broken tib fib, but in as much as the projections, it's just pretty simple. It's AP and lateral. So also there's going to be some positioning similarities with each one of these. You know, the lateral on the foot, the calcaneus, and the ankle are pretty much the only difference between those is going to be central ray location and collimation. Otherwise, positioning is fairly well identical. You may run into some questions or a question on the lateral. I'll point out what it is that question is going to be and why it is. I'll try to find the reference in the book. It's in the review I wrote. But at any rate, similarities are very, there are a lot of similarities between them. So toes. First off, procedural guidelines, make sure that anything that's on the patient, we get off the patient, make sure you've got all the stuff, required stuff on the image. Make sure you collimate. Collimation and masking after the fact is not the same thing, right? SID for the most part is going to be 40 inches. Once we get to the tib fib, we may increase that to 48 inches, and I'll tell you why. But everything else still applies. Make sure you put your markers on the image. Remove artifacts, shoes, socks. The elastic and socks will show up, so make sure you take that off. If they're wearing jeans or anything like that, make sure you roll those up. So, like I mentioned before, move the patient as little as possible. Most of these things you can do with a patient in a wheelchair. Their feet hurt, right? You might not want to get them up on the table. So consider shooting them on the floor. Well, how do I do that? Well, I'll tell you here in a minute. If you have to get them on the table, certainly get them on the table, but most of these you can do in a wheelchair. If they're on a stretcher, you're going to be shooting all these on tabletop anyway, so fundamentally what's the difference between shooting them on a stretcher and shooting them on tabletop? There is none, really. Right? So is there really any reason to get them off the stretcher, put them through all the hassle and waste your time putting them on a stretcher? No, not really. If it's a real busy night in the ER, is there fundamentally any difference between taking a portable to their room and doing these? The answer is no. Okay, so just some options, just some things to think about. All right, so collimation. Again, what are your 2 rules for collimation? Collimate to the part and never larger than the image receptor, right? All right, SID again is going to be 40 inches, markers, all that stuff. All right, so toes. We're going to do 3 view of toes. Sometimes you'll have an order for 2 view toes, and that's just going to be an AP and a lateral. A word that you need to file away that you're going to see on tests is a different projection aside from AP. So AP of the toes goes from the top of the toes through the bottom. The top of the toe is what you refer to, or top of the foot is what you refer to as the dorsal portion of the foot. All right, just like a dorsal fin on a shark or a dolphin, as the dorsal portion of the foot. The bottom of the foot, you know, if you ever played any kind of sports, basketball, football, your coach at some point probably told you to plant your foot, right? If you're playing basketball, plant your feet, take the charge, right? If you're playing football, plant your feet, you know, and whatever. So the bottom of your foot is the plantar surface of the foot. So the projection is dorsoplantar. It's the same thing as AP. Okay, so you're going to see both of those used, AP and dorsoplantar projection. So those are our most common, are going to be AP, and it's really AP axial. So just kind of mentally scratch AP and understand that in clinicals you're going to be doing AP axial. Same thing for the foot. In your textbook, it does the same thing, but it's going to be AP axial. In clinicals, if they say, you know, I want you to go get an AP foot, and kind of weird that we refer to people by their anatomy. Yeah, I want you to go get this AP foot, or AP and lateral foot. What are you going to do? You're just going to do AP? You're going to do AP axial, okay, for reasons we'll talk about in a minute. So it's going to be AP axial, and then notice there is no caveat in this one for axial for AP oblique. Okay, it's just going to be AP oblique, and no axial to it. And then you've got lateral. All right. So with toes, the difference between toes and fingers is that in toes, what we're going to do is we're going to shoot all of the toes. That's because you have a harder time pinpointing exactly where your pain is. You know, you get up in the middle of the night, you kick the door frame, and where specifically is the pain? Yeah, I mean, you kick the door frame and you say, where's it hurt? You say, here. You know, it hurts everywhere. So you can't really pinpoint it so well. So because of that, we can't be sure, his toes are gnarly. We can't be real sure as to where all the trauma is going to be. You know, did you break the lateral toe, which is probably, in my experience, the most common, you know, fifth toe, most common fracture of the foot. So you broke it, but did you break the one next to it? Well, I don't know, because everything over there hurts, right? I kicked it with one toe and I got 3 toes that hurt. So because of that, what we're going to do is we're going to shoot all of the toes at one time. I've never worked in a hospital that called for a single toe. Now for the lateral, you might shoot individual toes, and we'll talk about that here in a bit. But for the AP axial, what we're going to utilize is 15 degree cephalic central ray angulation, his toes upside down. 15 degree cephalic angulation, and our central ray is going to be to the head of the third metatarsal, or the third metatarsal phalangeal joint. So you're going to get about half of the metatarsals, and you're going to get all the toes, all 5 toes. Okay? 15 degree cephalic angulation, because your toes are at an angle, right? So what you're doing is you're putting a 15 degree cephalic angulation, because our toes are at an angle. You're going to use that 15 degree cephalic angulation, put the central ray parallel to the interphalangeal joints. Because it's a wedge shape, and the wedge is going down that way, our joint spaces are going that way, so we need an angulation coming this way. All right, 15 degree cephalic angulation for toes. Now once we get to the foot, we have the same issue. We still have a wedge shape, but we're going to knock that angulation down to 10. You're going to have a tendency to want to confuse those two, 10 and 15 degrees. 15 for toes, 10 for feet. Okay? You can also, you know, there is the option of using a 15 degree wedge sponge if you want to. Just a clinical tip here. You get the patient, this is especially a problem on the table if the table doesn't have a pad on it. You know, you got hard plastic on hard plastic, and then you put somebody's foot on it, and they've got their knee bent to 90 degrees so that they can put the plantar surface of the foot on the image receptor. So plastic on plastic slides real easy, right? Doesn't take anything to make a slide. So skin on plastic, you got a little bit of resistance there, right? So if you bend the patient's knee up and you put the light, you know, on the foot, you collimate it properly. Before you step back to make the exposure, hit that collimator light one more time so it stays on while you go back behind the control panel. Take one last look and make sure that they haven't, you know, scooted the image receptor and their foot out of the light field. Take one last look before you make your exposure. I don't know how many times I've seen, you know, you had everything perfect, and whenever the image came out, what you had was half of the metatarsals, the entire heel, and about that much, you know, direct exposure behind the image receptor. So take a look before you push the button and make sure that they're still in the light field. So that's 15 degrees posteriorly, 15 degrees sponge. All right, so now look at the wedge shape of the foot, right? So all of our obliques are going to be, for the foot, are going to be medial obliques, internal rotation obliques. Now the reason that we use that 15-degree angle, all of his toes are upside down. The reason we use that 15-degree angulation is because the toes are at an angle, right? But when we oblique up, looking at our foot from the front, or from distal to proximal, the fattest portion of our foot is down here, right? So as we oblique up, look what happens to the toes in relationship to where they were here. They're at a pretty good angle right there, right? As I oblique up, what happens? Are they at that kind of angle still? It's not as bad, right? And if we had a real foot here, it might be evident that they become parallel to the image receptor. So the reason for the angulation on the AP was to put the central ray perpendicular to the anatomy and parallel to the joint spaces. But as we oblique up, the joint spaces become perpendicular. We don't need that angulation. Okay, so AP axial for the oblique is just AP. Take the angulation off of the central ray, internally rotate, and we've got a range of angulations. It's 30 to 45 degrees. So the difference in those, and you can take a look at the patient and determine that, but the difference in those is the height of the longitudinal arch. So you got patients, you know, you'll have patients that their longitudinal arch is pretty obvious, and they've got a nice wedge-shaped foot. And then some of you patients, it looks like their foot is just, has no arch because they're flat-footed, okay? So look, though, at the shape of the foot before you make that determination. Some people are flat-footed pretty much from birth because they just have no longitudinal arch. But if they have a wedge-shaped foot, they're not flat-footed. Okay, so what happens over time is that, you know, things get a little saggy. You know, it's a tough reality that you're going to face one day. Things get a little bit saggy, especially if you've had traumatic injuries to your ankles. If you have a tendency to roll your ankles, then that's going to have effects in your ankles, but also in your feet. So what you may have is what they refer to as fallen arches. And they're not really fallen. The bony structure is still there, but what happens is all that fascial tissue that should be following the contour of the foot no longer does. You still got that good arch-shaped foot, but, or I'm sorry, you still got that wedge-shaped foot, but the arch just doesn't appear to be there. Ever heard of plantar fasciitis? Yeah, bone spurs. That's where those come from, is because of saggy arches, okay? So those are fallen arches. The arches don't really fall. What happens is that you've got, you know, the soft tissue just doesn't have the same, you know, elasticity as what it used to have. So I say all that to say this. Look at the shape of the foot. If it's good wedge shape, the higher, that means it's got a good arch, right? So the higher the arch, the more rotation. So 45 degrees If the patient's got a real good arch, not quite so high, if the patient has fallen arches, or not fallen arches, but flat-footedness. Okay? So that's the reason for the wide angle there. Okay. So for toes, lateral toes, we will do individual lateral toes, if at all possible. And this is going to be kind of painful for the patient. So what you might want to do is put so look at your AP, and then put them in charge of getting other stuff out of the way. So what that might entail is that you give them tape, and you wrap tape around, let's say it's the small toe, or pinky toe, wrap tape around everything else and have them hold and pull the rest of the toes out of the way so they can just see that one toe all by itself. Okay, I think in the textbook it shows using a tongue depressor, whatever works, you know, but you want to try to isolate that toe if at all possible. In a lot of cases it's not going to be possible. The patient's just not going to tolerate it. Okay, so in those cases though, the oblique will do a good enough job of showing anterior to posterior displacement that the lateral, you know, the lateral would be better, right? But the oblique will show it well enough that you don't necessarily have to torture the patient to get it. So you remember in hands, the lateral that we did depended on where the finger was, right? So if it was second finger, we would do with the lateral side down. And the same thing applies to the toes. If we're looking at lateral toes, if we're looking at 1 and 2, we're going to put the medial side down. If we're looking at 3, 4, and 5, we're going to put the lateral side down. Okay? So individual toes for lateral, for the AP axial and the medial oblique, we're going to do all toes at the same time. Okay? Any questions on toes? Really, foot. With a foot, there's a similarity between foot and toes are extensive, really. It's just central ray location, collimation, and a little bit of a change in the AP and the degree of angulation on the AP axial. So with the foot, again, we're going to back down to 10-degree cephalic angulation. We're going to direct our central ray to the third base of the third metatarsal. So we're going to include the entire foot. Again, everything else is the same. Flex the knee, plantar surface, leg vertical, all that kind of stuff. 10-degree cephalic angulation or towards the heel. Collimation, you know your collimation. The oblique's the same thing. It's 30 degrees, you know, from the plane, the sole of the foot, 30 degrees from the plant, the image receptor. No axial here. The lateral, okay, bears some explanation. So you got a couple of things on lateral. One is you can shoot the lateral, medial lateral or lateral medial. Either way, it doesn't really matter. I do want to bring your attention to something though. This will be our critical thinking question of the day on lateral foot. They took this out of the text, but I'm not sure that you're not going to see this on the registry, so it's worth bringing up. Okay, here it is. Under position apart, the first bullet point says, elevate the patient's knee enough to place the patella perpendicular to the horizontal plane and adjust a sandbag support under the knee. The heel should not touch the image receptor and the medial surface of the foot should be parallel with the plane of the IR. Okay, so that's the part that I really want you to focus on, is that the medial surface should be parallel to the IR. All right, so what they're saying is that if you put the patient's foot down, you notice because the heel is thinner than the distal portion of the foot, you see how the medial side is at an incline? What they're saying is elevate it so that it does that. Okay, so the heel shouldn't be in contact with the image receptor. All right, so until this edition of Merrill's, they stressed a thing that said that the you shoot lateral medial, medial lateral. Lateral medial is more comfortable for the patient, and that's what most people do. But medial lateral consistently, or lateral medial rather, consistently provides a better lateral. Now, why is that? Well, what did that last line say? Yeah, put the medial side parallel. So if you put the medial side down on the image receptor, guess what it is? It's parallel, right? Okay, so that's number one. You might see a question on a test, and this applies to foot, calcaneus, and ankle, all three, and that is that the lateral medial projection consistently provides, and it's pretty close to the wording that you may see, consistently provides a better lateral. Okay, as for that reason. But also, the medial side of the foot, you get home, I don't want anybody taking their shoes off, but you get home, take your shoes off, and take a look at your feet. Which side of your foot is fatter? Lateral side or medial side? Medial side. So you got a better base to put it on. Okay, the tendency is for positioning for all of those, be it ankle, calcaneus, or the foot, is to, you tell the patient put their foot on the image receptor, and they have a tendency to point their toes a little bit. All right? So when they point their toes, their foot goes into a little bit of a supination, and it really messes up your lateral. So you want your tarsal bones perpendicular, stacked on top of each other, superimposed, right? So the other thing, regardless of whether you shoot medial lateral or lateral medial, is dorsiflex the foot to 90 degrees. When you do that, it has a tendency to pull those toes and those metatarsals into where they're superimposed. Okay, dorsiflexion means to pull the toes back towards the shin. Okay, plantar flexion would be to point the toes. We want dorsiflexion to 90 degrees, and that gives us a better lateral. Now, tying all this up, foot and toes. What if a patient comes to you in a wheelchair? You gonna put them on the table? You can. You can if you want to. It's up to you. But can you shoot them in a wheelchair? The answer is yeah. The only thing that really presents any kind of challenge is the lateral, and it's not really a challenge all that much, right? You can take your image receptor, make sure the floor is clean, but take the image receptor, you can put the image receptor on the floor, put your patient's foot on the floor, on the image receptor that's on the floor. Your tube will come down to 40 inches from the floor, right? So you bring the tube down to 40 inches. If you're doing toes, 15 degrees cephalic angulation. If you're doing feet, 10 degrees cephalic angulation. You can shoot them still in the wheelchair. Have them hike up on a hip to rotate to the 30 to 45 degree internal oblique. It's always going to be internal oblique for feet. Okay, internal oblique. Medial rotation, internal oblique. You got your oblique. Take the angulation off the central ray, and you got your oblique. And then the lateral, what you may have to do is you may have to get a stool and shoot cross table. But that's not really all that hard, right? You just get a stool, you put the image receptor, you may have to use some tape to hold the image receptor up, and shoot a cross table, and you don't have to put the patient on the stretcher, or on the x-ray table. Okay? So, again, just a clinical tip. Use it if you want to. Don't if you don't. All right, so calcaneus. We'll do calcaneus and then we'll take a break. So calcaneus, we've got two projections. We've got a planto-dorsal projection, and then we've got a medial lateral projection. Okay? So what you're going to find in a lot of these you know, lower extremity, extreme lower extremity, we want dorsiflexion of the foot. This one's going to be tough for you though. It's going to be tough for the patient anyway. And that is because if you look on page 311, you see that dorsiflexion, and it might require the patient to actually physically pull the foot back. So why might that be an issue? Well, any idea what plugs into the backside of the calcaneus? What's that? The Achilles. It's the Achilles tendon that grabs right there, right? So when you pull your toes back, where do you feel the pull? In your gastrocnemius, right? In your calf. So if they've got a broken heel and they're dorsiflexing, what do you suppose that's pulling on? The Achilles, and therefore the broken heel. So it's going to be tough for the patient. And depending on how severe the fracture is, it may be diagnostic that if they can do that, it's not broken, right? If they can get to 90 degrees, it may not be broken. Maybe, but it may not be broken. So your patient is going to have a hard time getting there to 90 degrees, dorsiflexing the foot to 90 degrees. But if they can, then what we're going to do is dorsiflex the foot until the sole of the foot's forming a 90 degrees angle with the image receptor. And then we're going to angle the central ray 40 degrees cephalic. And in the book, you'll notice that they're shooting tabletop, which you should shoot tabletop. It's not thick enough that it really needs a grid. But also, some of your machines, you get up to 40 degree angulation, your machine won't shoot in the bucky, right? So you may have to do a tabletop. Play with your machine, see what the limits on the angulation are, but a lot of the machines I've used, you could not get a 40 degree angulation. It would automatically shut the machine down. Just think that you didn't know, not shut it all the way down, but keep you from making an exposure. Just thought you didn't know what you were doing, I guess. So tabletop, 40 degree angulation. Also notice the picture there, the centering is really pretty bad. So it under the description in central ray, and I think I put this in the notes, direct the central ray to the midpoint of the image receptor is cephalic angulation of 40 degrees, the long axis of the foot, entering at the base of the third metatarsal. So looking at that image and considering that you've got quite a bit of soft tissue on your heel, where's their angulation? Where's their central ray point? Pretty much that tubercle right there, right? So the base of the third metatarsal is going to be way up here. Okay, so you know when you have to do one of these, and you will, it's not uncommon. Somebody falls from a ladder or out of a tree or whatever. They very well may break their heel, but you know, your central ray don't lock that image in, or you may clip a portion of the calcaneus. The central ray is going to be a bit higher. Okay.
If they can't dorsiflex their foot,
That's exactly where I was going next. So if they can't dorsiflex their foot, get this. So watch. So you got 40 degree angulation at 90 degrees. This is visual. Just to increase your angulation. Okay. May not be ideal, right? And it won't be ideal. 90 degrees and 40 degrees, that's ideal. But it's, you know, if you leave the angulation the way it was and your foot is plantar flexed, you're going to get increased superimposition of at least soft tissue, if not more bone, over the calcaneus. Okay? So if they can't get it back, then just increase your angulation. Try to come up under it. So another option, if you look on page 312, that's another option. You can shoot it dorsoplantar. Not sure that that's on the test, but you know, from a clinical perspective, that might be an option for you. We're going to skip over all the obliques, and we're going to go to, where'd it go? Oh, There it is, on page 314. So if you read through positioning of the part, really we've got a lot of the same steps that we had for the lateral foot. So in this case, really the only difference, the primary difference is going to be central ray location collimation. So with the foot, it was to the base, is kind of a guess, but to the base of the third metatarsal. In this case, where we're going to go is 1 inch distal to the medial malleolus. So assuming that you're shooting medial lateral, again, most of the time you're going to shoot medial lateral because it's easier to do. You know, you get a patient on a table, you know, it's easy to just flex the knee and put the lateral side down. It's a whole lot harder to, you know, get the medial side down. So you're going to shoot medial lateral, and your central ray is going to be 1 inch below the medial malleolus. Okay? Any questions?